My name is Dr. Tudoran Cristina, and I am Assistant Professor at the University of Medicine and Pharmacy, Victor Babeș, Timisoara, Romania. I would like to thank you, the ICBioMed 2023 coordinators and organizers, for inviting me to join this conference. I would like to present you the importance of transthoracic echocardiography in the evaluation of patients with Covid-19 syndromes. Coronavirus disease 2019, or short COVID-19, is caused by the severe acute respiratory syndrome coronavirus 2. It was first discovered in Wuhan, China in December 2019, and since then it has spread worldwide, affected millions of patients. This is why, from 30 January 2020 until 5th May 2023, it was declared by the World Health Organization a public health emergency of international concern due to the development of vaccines. Since 2nd June 2023, because the number of daily new cases has dramatically decreased, it is still considered only a pandemic, no longer a health emergency. This infection spread wave-like with the highest incidence in spring 2022. The incidence of daily new cases decreased, and the most rapid and significant reduction in daily new cases was determined in June, from June 2023. We have a total of approximately 690 million confirmed cases, with approximately 6,894,000 deaths and over 660 million survivors. All continents were affected because of the high number of patients who needed specialized care. The healthcare system had to adapt rapidly. Most healthcare professionals focused on the acute COVID-19 disease, but soon it became clear that survivors who were considered recovered continued to present symptoms which limited their daily activity. In August 2020, Greenhalgh mentioned for the first time post-acute COVID-19 syndrome. We now know that there are in fact two COVID-19 syndromes. They are characterized by the persistence of symptoms after the patient should have recovered from an acute infection. These symptoms should not be attributed to coexisting pathologies or to adverse events of vaccine. The most frequent encountered symptoms are cardiovascular, pulmonary, renal, and neuropsychiatric ones. Depending from the duration of the symptoms, the COVID-19 syndromes are divided into two entities: the post-acute COVID-19 syndrome and the long, post, or chronic COVID-19 syndrome. Post-acute COVID-19 syndrome is defined by the persistence of symptoms 3 to 4 weeks after the initial infection and until 3 months. It is more frequent in women. Typical symptoms are tiredness, dyspnea, fatigue, brain fogginess, autonomic dysfunction, headache, persistent loss of smell or taste, cough, depression, low-grade fever, palpitations, dizziness, muscle pain, and joint pain. Its incidence varies according to the studied population. In the general population, it ranges from 10 to even 35%, while in hospitalized patients with severe forms of COVID-19, it may reach even 85%. Approximately 57% of COVID-19 survivors have one or more long COVID-19 features recording during the first 6 months. Long COVID is defined by the persistence of symptoms from up to 3 months from the acute infection. Frequently encountered symptoms are similar with the ones from the post-acute COVID-19 syndrome. Its incidence varies from 7.5% to even 41%. Practically, every person who survived one, two, or more infections with the various strains of SARS-CoV-2 can develop COVID-19 syndromes. The risk is directly correlated with the severity of COVID-19 disease, expressed by the lung damage evaluated by chest computer tomography and the oxygen saturation on pulse oximeter, the severity of the inflammatory response, associated pathologies, and age. In order to quantify the impact of COVID-19 syndromes on the well-being of the affected individuals, Flock developed in 2020 the post-COVID-19 functional status scale. It quantifies the functional limitation of the survivors of COVID-19 from no limitation, which is grade 0, to severe functional limitations, which is grade 4. In the literature, there are conflicting results regarding the effects of anti-COVID-19 vaccines on the severity and incidence of post-acute COVID-19 syndrome. A main limitation of most studies was the short follow-up period. The spectrum of cardiovascular complications on the heart is very large, ranging from sinus tachycardia or hypotension to various arrhythmias, myocardial ischemia, acute myocarditis with heart failure, or even pulmonary thromboembolism and right ventricular dysfunction. The most frequent encountered cardiovascular symptom is shortness of breath, which is determined at 3 months after an acute infection in around 36% of the affected individuals. Chest pain is a complaint declared by 20% of the survivors at 60 days after an acute infection, and it continues at 6 months to be mentioned by 5% of patients. Palpitation is declared in 9% of the patients at 60 days. Other symptoms are fatigue, failure to achieve the basal effort tolerance, and reduced effort tolerance. The mechanisms of cardiovascular alteration in COVID-19 syndromes are multiple, like prolonged inflammatory responses, endothelial dysfunction or even vasculitis, venous and arterial thrombosis, mycothrombogenesis, myocardial fibrosis, and myocardial stiffening. Due to the high number of affected patients, some of them with cardiovascular diseases or patients who develop new cardiovascular pathologies after COVID-19 infection, the European Society of Cardiology developed the guidelines for the diagnosis and management of cardiovascular disease during the COVID-19 pandemic. Transthoracic echocardiography is a useful and non-invasive tool for the cardiologist to assess um, the structural damage in the heart. It should be performed in patients with post-acute COVID-19 syndrome who present elevated D-dimer levels, NT-proBNP and BNP levels, high sensitive troponins, CK and CKMB. In individuals who have new modifications on the REST ECG, in those with associated cardiovascular pathologies which have worsened after a COVID-19 infection, and in patients considered at risk to develop cardiovascular alteration after a COVID-19 infection, like obese patients with diabetes or with pre-existing pulmonary hypertension due to pulmonary pathology. It should be performed after a detailed clinical examination and following the recommendations of the American Society of Echocardiography and the European Society of Echocardiography. Multiple studies mentioned a higher risk of developing the following cardiovascular syndromes in COVID-19 syndromes: pulmonary hypertension, right ventricular dysfunction, left ventricular systolic and diastolic dysfunction, myocarditis, pericarditis. Pulmonary hypertension is often encountered in COVID-19 survivors. Accumulating evidence supports the notion that SARS-CoV-2 infection is indeed a risk factor for persistent pulmonary vascular defects and subsequent pulmonary hypertension development, and this could become a major public health issue in the future given the large number of affected individuals. Pulmonary hypertension is one of the most frequent cardiovascular pathologies in patients recovering from COVID-19 infection. The incidence is around 15%. The guidelines recommend the following parameters to be assessed in order to quantify right heart dysfunction. We measure in four-chamber view right atrial and right ventricular diameter, fractional area change, tricuspid annular plane systolic excursion, short TAPSE, tricuspid regurgitation velocity, which helps us calculate non-invasively the estimated systolic pulmonary artery pressure, a parameter which allows us to assess if a patient has or has not pulmonary hypertension and its severity. It correlates with the pulmonary artery pressure, which is measured invasively during right heart catheterization. With the help of estimated systolic pulmonary artery pressure, we consider mild forms of pulmonary hypertension if the value is between 35 to 44 millimeters mercury column, moderate forms with values between 45 to 59, and values over 60 define severe forms of pulmonary hypertension. We can also measure during transthoracic echocardiography pulmonary vascular resistance. A newer marker or parameter which is very accurate is right ventricular global longitudinal strain. Together with TAPSE helps us determine if a patient has or has not right ventricular dysfunction. In this image, we see a tricuspid regurgitation, and with the help of the modified Bernoulli formula, we can calculate the estimated systolic pulmonary artery pressure. In order to assess left ventricular systolic function with the help of transthoracic echocardiography, the most frequently used parameter is left ventricular ejection fraction. But we also measure lateral mitral annular systolic excursion. During tissue Doppler imaging, we determine average systolic mitral annular velocity. Experts recommend to use left ventricular global longitudinal strain instead of ejection fraction or together with ejection fraction to quantify left ventricular systolic function. For diastolic dysfunction, we assess left ventricular mass index, left atrial volume index, and with pulse Doppler and tissue Doppler imaging, we can measure the peak early diastolic velocity and the late diastolic velocity in pulse Doppler and in tissue Doppler imaging, which allows us to determine the E per A ratio and the E per E prime ratio, which allows us to quantify the severity of diastolic dysfunction. A newer parameter is left atrial strain. Acute pericarditis is one of the most frequent cardiovascular alterations. It extends from post-acute COVID-19 syndrome to long COVID. If transthoracic echocardiography is performed in the first weeks after an acute COVID-19 infection, it usually finds a pericardial effusion, moderate or small. This effusion regresses rapidly. The most frequent manifestation present even in the first weeks and which can continue to be present even at months after the acute infection is thickened pericardium. The incidence of acute pericarditis is around 22%. In this image, we see a thickened pericardium with a small effusion. Because of its accuracy, left ventricular global longitudinal strain is considered a better parameter than ejection fraction to quantify left ventricular impairment. The impairment of left ventricular global longitudinal strain can persist at 2 months after an acute COVID-19 infection. If it continues to be present at over 6 months after the first symptoms of an acute COVID-19 infection, it is considered a factor for prolonged cardiac damage due probably to myocardial fibrosis. It is measured in 3, 4, and 2-chamber view. Diastolic dysfunction is considered to regress slower than other cardiovascular pathologies. This is why it has a higher incidence in long COVID. Some studies demonstrated that the A per A prime ratio can increase during low-level exercise in patients with myocardial injury, and it suggests a worsening of left ventricular diastolic dysfunction during effort. Although pulmonary hypertension improves over time, it can last for months after an initial SARS-CoV-2 infection. The persistence of pulmonary hypertension with or without right ventricular dysfunction is a negative prognostic factor. Some studies have demonstrated that both these pathologies worsen during exercise. Experts recommend right ventricular global longitudinal strain for the assessment of right ventricular dysfunction. It is measured in 4-chamber view. Thank you very much.